Thank you very much for the introduction tour. And my name is Erlend, and I'm a pediatric ophthalmologist and a researcher at Oslo University Hospital in Norway. So I took my PhD on aniridia, mainly on ocular surface disease, and have proceeded with some research now regarding mostly quality of life, because that was a request from the patients and the patient organization Aniridia Norway, among others, to look into that topic, because not so many others have done that. So it's quite another topic, but I think it's important to highlight those aspects of life and health. So what is quality of life? I didn't know that actually very well when I started with the research. It was new. Okay, everyone can imagine what quality of life is in some way, but what is it actually? It's a little bit difficult for me to define. But it could be said that it's the perception of life in itself, its positive and negative aspects of life. And that may be very diffuse and not very concrete, but yeah, it's a very personal or emotional feeling in a way of life. And the topic today is health-related quality of life. And what is that? That is simply how health impacts quality of life. And that could be very different from person to person. A disease may impact one person very differently from another. And that may also change during life. When we are older, we may handle a disease differently than when we are younger. And we may handle a disease differently based on, for instance, our background, our economic background, our education, and so on. I will come back to education because that's actually an important issue. So what is health? Actually in 1977, Engel, he proposed the biopsychosocial model. And that is composed of the physical health component, the mental health, and the social health. And the last one is also very important. And we recently have had a debate in Norway about this model. Is it correct? Is it covering all aspects of health? Spiritual or emotional health, for instance, is it model covering these aspects good enough? We don't know, but there is an ongoing debate in Norway about this. So what does the literature say about mental health and visual impairments? It's relatively clear that people with reduced vision, they are more likely to have anxiety and depression. And we also know that the quality of life is reduced in people with reduced vision. And it could be comparable with serious medical conditions. So it could substantially impact the quality of life. And one study also showed that if you get visual deterioration or reduction before age of 12 years, that may also increase the risk of depression and anxiety. So that may count for aniridia, for instance, because it's a congenital disease. But we need to know more about it. We don't know. I think the literature is not good enough to say enough about it. So we went together with what is called the Center for Rare Disorders in Norway, which covers actually very many rare disorders, and they give consultants and so on to all these people, and we conducted a study which is published in 2 papers shown here. The first one I will talk about today mostly is published in Ophthalmology, Ophthalmologica, and it's about health-related quality of life in congenital aniridia. And we sent an invitation to, I think, 49 people with congenital aniridia in Norway, aged 16 years or older. And we had 29 participants in the study. So it's not very many or a huge number, but still we were satisfied with the participants or the number of participants. So a little bit about the background information. I talked about education, and that education could be a very important factor related to quality of life. And surprisingly, actually, we saw that a relatively high percentage of the participants had high education. That means at least 1 year at university, college, or university. Approximately half of the participants had that education at university, college, or university. And if you compare that to the Norwegian population, only 30% of the adult Norwegian population have the same level of education. So the education level was much higher in the Aniridia population. And one may speculate why, but there are some theories about that. And what about the diagnosis of the mental health diagnosis? We asked, are you diagnosed with depression or anxiety or sleep disturbances? And about 19% said that they had depression and 14% had anxiety. And sleep disturbances were also highly prevalent, and 62% said that they had one kind of or any kind of sleep disturbances. And then we chose to look at ocular pain because we thought that may be an important parameter or factor. And as much as 60%, 61% said that they had ocular pain to some degree. And we asked, how frequent is the ocular pain? And on average, a participant had ocular pain at least weekly. And how strong was it? It was, on a scale from 1 to 10, it was approximately 4. So it was moderate pain, but still relatively frequent. So how was the health-related quality of life in our population? We compared our data with normal data from the Norwegian population, and we found that the Aniridia population scored significantly lower on what we call the general health domain of health-related quality of life. And we used the so-called SF36 questionnaire, which is a standardized questionnaire used in several studies to compare or to examine health-related quality of life. And that questionnaire consists of 8 domains. And other domains may be, for instance, social functioning, mobility, and so on. But looking at these 8, it was only the general health domain that came out significantly lower than the general population. And interestingly, we saw that when we looked at women and men separately, it was only women who scored lower on general health, but not men. But men, they scored lower on social health. And if you look into the Norwegian population or the data from the Norwegian population, we also see a tendency to that men have score lower on social health. So that is, in a way, a same tendency in the Aniridia population as in the general population. So we also used what is called a visual analog scale, and we asked, what is your perceived health as of today? How good is your health today? And you had to score it on this scale from 0, which is the worst health you can imagine, and 100, which is the best health you can imagine. And then we also saw clearly that the Aniridia populations go lower on this scale than the Norwegian population. So we also saw that as an indicator of lower health-related quality of life in the Aniridia population. So what about anxiety and depression? You saw that approximately 15% said that 18% said that they had depression, and 14% said that they had anxiety. And then we used what we call the hospital anxiety and depression scale. And it consists of several questions measuring symptoms of anxiety and depression. And surprisingly, actually, we found that more than 30% scored a value consistent with the diagnosis of anxiety. That's almost one third of the population of the study sample. However, only 7% scored had a score that was compatible with depression. So it seemed like anxiety was an underdiagnosed condition in this group. However, depression may be overdiagnosed or well treated and maybe well treated. So that's an important point to address. And we asked the participants about their weight and their height, and then we calculated the body mass index. And the average body mass index in our sample was approximately 31, and that is compatible with obesity. And women, they had slightly higher body mass index than men, and men had 29, I think. And then we used what is called the patient-reported outcomes in obesity, which is a questionnaire where we ask, how does your body weight or body shape bother you, or do you have any discomfort due to weight or body shape? And then the participants said that they had mild discomfort due to overweight. But still, the range was very, very big in our cohort. And we had a big range in weights, and also then in this score or PROS score. So, which factors are associated with health-related quality of life? And we did a correlation analysis, and then I said that education was important. And I don't know, do you have any suggestion? What did we find there? Do you think that higher education will give better health-related quality of life, or the opposite? What do you think?
The opposite. They feel they can
Yeah, you think that higher education will give lower health-related quality, or the opposite, or no, the opposite? Yeah.
If they feel good, they can educate more. They can take more education.
Yeah, yeah. That's logical. And if you look at the Norwegian data, you actually see that on all domains, you see that those with higher education they score higher on health-related quality of life, on all those 8 domains: social, functioning, general health, and so on. But in the Aniridia group, it was the opposite. Those with higher education, they scored significantly lower on the general health domain. So it didn't seem to be any good to have high education in the Aniridia group. And why is that? We can speculate and we can discuss that later, but there may be some factor of, for instance, people taking a long education and then not getting into job and feeling that loss afterwards. You have a high education, for instance, university, high education, and then you don't get into job. And we saw a high percentage in our group that were unemployed compared to the Norwegian population in the Aniridia group. So that may be an explanation. Sorry. And another interesting finding was that ocular pain was clearly associated with health-related quality of life. Those with high or more pain, they had lower quality of life. And that was actually a factor that was we saw on several parts of the study, that ocular pain seemed to be very important. That seemed to be a very important factor. And it was also clear that symptoms of anxiety and depression were associated with lower quality of life, especially what we call mental quality of life, and discomfort due to weight and body shape. Those 4 factors. Yeah.
Did you see any correlation in the Aniridia group between the lower education group subgroup and the higher education subgroup and the anxiety level, and then compare that with the quality of life perception?
Yeah. We didn't do that, but it would have been interesting to do it, but we didn't investigate it further. But it's very interesting, and we have small numbers and so on, but it would be very interesting to look at that. In that other study that was published, we look at executive functions and so on, and we found that ocular pain also was connected to difficulties in executive function or doing daily tasks, with sleepiness and fatigue. So also in this area, ocular pain was important. And 17% had daytime sleepiness, and 38 met the criteria for fatigue. So in conclusion, the general health-related quality of life in the Aniridia group was lower than in the Norwegian population, and lower quality of life was clearly associated with symptoms of anxiety and depression. And we also saw a correlation between higher education and lower quality of life, and between increased pain and also with problems with weight and body shape. So what consequences should this have for the clinician? I think it's very important to address especially symptoms of anxiety and depression, and maybe refer the patient to a primary doctor or a psychiatrist for evaluation. Anxiety seemed to be very underdiagnosed. I think we should ask we should ask about ocular pain. I've started with that now. Do the patient have ocular pain? That seemed to be a very important factor, actually. More important than low vision. If you had high pain, that was much more important for the quality of life in our study than lower vision. And of course, we had have to address the issue of overweight. So the last slide is from Norway. It's the Nærøy Fjord, which is on the World Heritage List, together with Geiranger Fjord. And if you haven't been there, you should visit the west coast of Norway. Thank you very much.
You go first.
Thank you very much for your presentation. I would like to make one comment, not as a representative of Aniridia Europe or mother of child with Aniridia, as a psychologist. I have a PhD in psychology. I've been studying for 7 years. And my presentation was in Aniridia Conference in UK, 2021. I have like 103 respondents about how Aniridia itself and vagal spectrum can affect mental health. So if you like, I would like to share with you my studies. Because some data is really similar with what I was studying 33 psychological states, we call it like this, and how in these 33 specific psychological states, what is the difference between, let's say, people without aniridia and people with aniridia, and family members of patients with aniridia were included in the study, and family members of kids with vagal spectrum. So it's very interesting. So out of my study, the result was that not only patients with aniridia itself have dramatic changes in the palette of psychological states, but also the family members, and it was really extremely interesting. So if you like, I would like to share my study on this. Yeah.
Absolutely.
Thank you.
Thank you.
Great. One final question, Erlend. Is it okay?
Yeah.
How can depression influence ocular health? And then I am not surprisingly thinking of dry eye disease. Any mechanisms, any thoughts from you or any others?
Yeah, I know there is a connection between depression and dry eye disease. Well, that's the question. Yeah,
Yes.
I know that. Yeah, that was your question, or no?
Yes, and the mechanisms. How can depression influence the occurrence of dry eye disease? Maybe you would tend to go for some antidepressants, and
Medication,
maybe they may have some side effects. And
reduce blinking range. Frequency.
Yes, exactly. So that's why maybe driving convertibles may also be good in a way, because you have this feel-good experience. So just to connect the talks.
Yeah, very good.
Great talk as always. Thank you so much. Perfect.